All right, so this is Gatorade's first official video. I have no idea if this even works properly. Hopefully you can hear me okay. The point of this is to make a couple shotgun videos where I just go over random topics that I think will help you both with step 2 questions as well as your psychiatry rotation. So let's just get into it. The first thing you really need to master when it comes to your psych rotation is just the different brand names you're going to hear. Some of the most common ones I heard on my psych rotation were that of the SGAs, the second generation antipsychotics. Some people call them atypical because they don't really work through a classic dopamine blockade like the first gens do. So I'll let you read them. Some of them you're probably already familiar with. The ones that were new to me were Invega, which is paliperidone, Vraylar, which is cariprazine, lorazepam, which is Latuda. I feel like the rest of these I'd heard of. Really the most frequent ones that I saw being used are Abilify, ZYPREXA, Seroquel, GEODON. They're certainly all used, and the nuances of selecting different antipsychotics, I think, are generally probably out of the scope of this video. The two things to know is that clozapine causes really bad agranulocytosis. So if you see anything about a second-gen antipsychotic and they've given you a CBC with really low blood cells, you're probably talking about clozapine. And for that reason, it's not really first line for anyone. The other one is going to be ZYPREXA, also known as olanzapine. Really the buzzword for this is weight gain. If you have a patient who was on an antipsychotic and they've gained a ton of weight, they were probably on ZYPREXA. Really one of the most important things that you'll encounter is eating disorders. So what is exactly a feeding and eating disorder? There's a couple of them. I'm sure you're familiar with most of them. Pica is one where you want to eat something that is not food, like for example, cornstarch, dirt, ice chips, etc. Usually it's associated with anemia. Rumination disorder will usually be presented in the context of a mentally disabled child. The rest of these you're probably pretty familiar with. Signs of binge eating. This one, I think the test questions on this will be pretty easy, but you really have to be familiar with binge eating disorder so you can take care of your patients. As people become more and more sensitive about their weight and try to counteract that in whatever way they see fit, I think you'll have more people suffering from this. Really, the answer to any eating disorder question, what you need to know is that it's going to be treated with cognitive behavioral therapy. And if you have life-threatening anorexia, typically they'll really be hovering on that BMI less than 17. Usually you want to do inpatient admission. The reason why is refeeding syndrome. If you just try to treat this outpatient, you could be talking about some very dangerous electrolyte and blood sugar swings that could be very deadly. This is a really good way to think about it. For test questions, they really like to segment based on BMI. So if you have a BMI less than 18.5, you're automatically talking about anorexia. Within this, you can specify if they're the restrictive type or the purging type. If they have a normal to elevated BMI, you're probably talking about either a binge eating or a purging. So they could either be bulimic or not. Typically, the way this presents is they kind of try to confuse you, and you'll think you're dealing with an anorexic purging patient, but you're actually dealing with bulimia nervosa, and that's based on their BMI. You could get a lot more into this, but this initial framework is really helpful for categorizing which patient is which. This is a physical exam finding. You'll see this kind of surreptitiously inserted into test questions. They'll say there's like excoriations or blistering of the knuckles, and you'll be like, what does that have to do with anything? And what they're talking about there is the Russell sign. So the idea behind this is that someone who's purging a lot, they're kind of sticking their finger into their throat to induce vomiting, and that usually scars their teeth. Scars their knuckles from their teeth. And usually what this is trying to tell you is that someone is purging. The other thing that I wasn't too familiar with is something called lanugo. These are fine body hair seen in malnourished states, for example, anorexia. The pathophys of why this happens is kind of not really too relevant, but essentially I think it has something to do with a lack of fat leading to some problems with insulation. I think, not really sure exactly why. It has something to do with calorie restriction. Another random finding is going to be bilateral sialadenosis, seen in anorexia. These are called chipmunk cheeks, because that's a lot easier to say. Essentially what this means is that someone who's vomiting a lot, they're kind of causing damage to their parotid glands, and those are going to swell up. I think this is managed with ice packs mostly. It kind of just goes away on its own. This is not to be confused when this is unilateral. Usually that is treated with antibiotics and sucking on lemons. Now we're kind of getting more into the level 2 concepts. One thing about level 2 versus step 1, kind of present things you already know, but kind of in a weird way, in a more like clinically subtle way. So you might have a question where they honestly tell you nothing about anorexia. They're not going to like tell you it's a patient that's concerned about their body weight or anything like that. They're just going to give you a healthy-ish patient plus some weird lab value. So that might be something like low albumin from protein calorie malnutrition. Or the one that you're really going to see is someone who's vomiting a lot. They lose a lot of stomach acid, which contains hydrogen chloride. So the good way to think about that is not only are you losing chloride, but you're losing hydrogen ions. So when you test their serum pH, you're going to have a metabolic alkalosis from the loss of the hydrogen, and you're also going to have low chloride levels from loss of that chloride. This can really be a subtle finding that kind of helps you just get one more question right. I think this is a really useful tool to keep in your back pocket. If there's ever a metabolic alkalosis and you're like, they're not telling me anything about this patient, but for some reason they just say like woman, something about BMI, like just trying to basically stereotype your patient for you, and you see that low chloride, you really want to be thinking about surreptitious vomiting. Kind of getting more into, I think psychiatric and primary care of the female patient are very intertwined. So one thing you'll see a lot in test questions is something called the female athlete triad. This is basically 3 things. So you have calorie restriction, basically a calorie deficit. You have amenorrhea and osteoporosis. This is the female athlete triad. One thing to note when taking care of real life patients, you might have an athlete that's describing a pretty normal diet, but you really have to work with a dietitian and kind of figure out what their actual caloric goals are, because you have to realize that, like an athlete putting in 2 to 3 hours of practice a day, they might burn up to 2,000-3,000 calories, especially sport like soccer or swimming. So you really have to make sure that calorie intake is really where it needs to be. This is a scary slide, but basically kind of getting into that higher level clinical pathophys. When you think about hypothalamic amenorrhea, this is something you see a lot in patients with anorexia, induced starvation, low energy levels, chronic starvation. What you really see is that they stop having periods as frequently. And when you think about why this is, it's actually kind of fascinating. So leptin is a hormone in the body that tells the body to stop feeding, basically. It's like the hormone that tells you that your body is full. So usually what that does is it kind of stimulates the release of hypothalamic hormones that ramp up the thyroid, the ovaries, and the adrenal glands. So when you have low leptin from a chronic starvation state, if your body's always hungry, what happens is that you stop making LH and FSH. And when you do that, you basically um, stop having ovulation, you stop having periods. And the reason why is that that LH surge never happens. So this is something to think about when you have a patient and, unexplained loss of periods. You really need to start thinking about calorie restriction. You really need to start thinking about anorexia. It's all about putting together those fancy graphs that you see here with the real life scenarios and the real life clinical encounters. This might also be a thyroid question. We're not really talking about that right now. But as you can see, this raises cortisol chronically, which when you have a patient with chronic cortisol elevations, that kind of branches off into a whole separate discussion that we won't get into here. So a good thing to remember with the treatment of different anxiety disorders, we could go into all of them, but really if you had to pin it down to like a 5-second thing, SSRI plus CBT, that's a good answer choice for pretty much everything. One thing I want to call your attention to is when it comes to most anxiety disorders, they have to have been present for at least 6 months. So if you have a question where they're like really emphasizing that something's been going on for a year, you kind of want to back up and be like, oh, why are they telling me this? And it's usually because they're trying to get you to diagnose something like generalized anxiety disorder or specific phobias, etc. Really, with all these, kind of the theme that I got is you never really want to treat anxiety with a benzodiazepine, at least at first, because they can be very habit forming. Typically, they're really going to lean on that cognitive behavioral therapy as a crutch in these test questions. Obviously, in real life, it's a little more complex, but for a test, SSRI plus CBT, you can't go wrong. This is a question that's been popping up more on test questions as you try to integrate psychiatry, primary care, and obstetrics, or gynecology rather. This is something called PMDD. So this is premenstrual dysphoric disorder. It kind of, it's a DSM-5 entity that was created to explain basically PMS symptoms, but more severe. That's really the crux of it. So you're going to kind of hone in on buzzwords and questions like interfering with schoolwork, unable to perform tasks at work, like something that tells you that it's interfering with their life in a significant way, more than just typical PMS. So this disorder typically happens in the luteal phase of the menstrual cycle. So kind of tying this all together, integrating different organ systems and different fields of study. If you remember, once you ovulate, once you release that follicle, the body starts the luteal phase where progesterone is high. So this is when PMDD really occurs. And some different questions that I could ask you is kind of, what's the oocyte doing once it's released after ovulation? So it's just chilling in metaphase 2. This might be something that you see more as a step 1 question. But long story short, PMDD is treated with an SSRI. One thing to note when you're dealing with prescribing medications to females of a childbearing age, paroxetine, brand name Paxil, this is contraindicated in pregnancy due to a risk of heart defects. One thing that when we're tying in the luteal phase of the cycle, I won't dwell on this too much, but progesterone raises the body temperature because it acts on the anterior nucleus of the hypothalamus. The reason this is important is there's been a resurgence lately in the method of fertility tracking via body temperature. So, if you have patients asking you, hey, why does my body temperature even rise? Like after I ovulate, what's going on there? It's because of progesterone and how it acts on the hypothalamus. So I thought that was really cool. One thing while we're talking about progesterone, it's made in the theca cells. So you can see here with the follicle, you have the theca cells over here, and that's where progesterone is made. So kind of tying this all together with endocrine physiology, the way it works is that LH stimulates the theca cells. That makes progesterone, which then becomes testosterone, and that testosterone is shuffled to the granulosa cell, which under the stimulation of FSH becomes estrogens. So this is kind of how you have the ovary fine-tuning the balance between progesterone, testosterone, and estrogen. And when that balance becomes altered, you might have something like hyperandrogenism, so too much testosterone, and you would then have a patient with PCOS possibly. So, when you're taking care of one disorder, maybe you're seeing someone for a psychiatric reason, you always want to be thinking about how this relates to their other diagnoses and their other conditions. One other random bullet, you really don't hear too much about mirtazapine in the preclinical years. At least I didn't. So this is a new class of atypical antidepressant. What that means is that it doesn't really work too much just on serotonin. It also works on norepinephrine. And it has some anticholinergic effects as well. So if you have a patient who is depressed, they have no appetite anymore, they're not getting much sleep, this might be a great drug for them because it's going to put them to sleep pretty well and it's going to help them regain their appetite. Obviously, in real life, you would want to tailor this to the individual patient, but this is something you'll see on board questions when the patient with insomnia, they want basically not an SSRI, they want something else. This could be a great option. So that was about it for this first round of videos. I hope that was helpful. Thanks.